So hello and thank you for joining us for our discussion on this important yet often overlooked topic of screening and addressing food insecurity in the emergency department. My name is Elizabeth Scott. I'm a first-year EM resident at Harbor UCLA. Our presentation today includes representatives from LA County, Harbor UCLA, and Boston Medical Centers. We have no financial disclosures.
The USDA defines food insecurity as the limited or uncertain availability of nutritionally adequate and safe foods, or uncertain ability to acquire acceptable foods. There are 4 gradations of food security seen here. Recent estimates during COVID find food insecurity to more than double from 2019, affecting as many as 23% of households in 2020, hitting households with children the hardest. Per the Brookings Institution, around 13.9 million children in the US lived in a household characterized by child food insecurity. So our social histories in the ED often ask about smoking use and medical problems such as hypertension and diabetes, but this data from the CDC suggests we should really be asking about food insecurity. More deaths are associated with food insecurity than tobacco use, and furthermore, a 2020 paper in the Western Journal of Emergency Medicine reports patients screening positive for food insecurity in the ED were more likely to be admitted to the hospital and have significantly higher HbA1c levels.
Is that Hannah?
It's me still.
Oh,
sorry. So eating better not only saves lives, it saves money. This chart from the Hood-Sexo Foundation back in 2007, sorry, someone just walked in. I got distracted. Okay, this chart comes from the Sodexo Foundation back in 2007. We anticipate that these costs have only risen as healthcare continues to increase in price. Food is a billion-dollar industry. Millions of dollars are annually poured into advertising alone, primarily for highly processed food. Problematically, these advertisements are largely targeting our youth and economically disadvantaged populations. The 2012 Federal Trade Commission reports food companies spent about $149 million in schools in 2019. 93% of this was marketing for sugar-sweetened beverages to kids that contain an average of 19 grams of added sugar.
So looking at the importance of food insecurity to health, we asked ourselves how to apply this to our patient population. At Harbor UCLA, we serve a largely low-income population in South Los Angeles. We use the hunger vital sign, which is a 2-question model that can be used by a busy ED physician or staff member to identify those at risk for food insecurity. The hunger vital sign was originally validated in pediatric literature by Hager et al. In 2010, and then subsequently applied to adults by Gunderson. We also designed a prescription for our EMR system that can be printed with discharge papers to refer patients to our food pharmacy. We learned a lot through the process of creating, maintaining, and beginning to study the efficacy of the food pharmacy. From the beginning, Dr. Shea was able to utilize existing organizations in line with our mission to form vital partnerships instead of starting from scratch. For example, the American Heart Association was already actively working to distribute produce to other LA communities, and we at Harbor were able to partner with them for ongoing support in the weekly transportation of food to our food pharmacy, the major cost of running it. Additionally, we partnered with Food Forward, a local organization that reduces food waste through collecting excess produce from farmers, grocers, and local harvesting for redistribution, creating a win-win situation of reducing food waste in addition to providing better food security for the community. In addition to those valuable pearls, we definitely experience our fair share of pitfalls in this process. Maintaining our prescriptions, as seen on the previous slide, where patients were directly referred from the ED with a paper prescription, became increasingly difficult to maintain. And we now operate on more of a word of mouth model. This makes our current setup more of a distribution center as opposed to a strict food pharmacy, but also allows us to serve a wider population surrounding our hospital instead of limiting us to just those seen in the ED.
This is Hannah?
Yeah.
Okay, so Hannah. Hi, Willie. We're just briefly running through.
Hi, Hanny. Hi, folks. My name is Willie Baker. Thanks for having me.
Hi, thanks for joining us.
Okay, so this is also Hannah.
Yes, it's
Okay.
Hannah until you, I think.
Okay, great. So hi everyone, my name is Henny Hong, second year EM resident coming from Boston Medical Center on the opposite coast. I'm honored to be here today. I wanted to briefly talk about what Boston Medical Center is doing to address our patients' food insecurity. Since 2017, Boston Medical Center has implemented a Thrive program that focuses on screening for social needs for our patients and addressing their needs. And as of September of 2020, we have implemented a partial screening in our very own adult ED. So the current flows includes a patient who's eligible for screening gets screened using a validated screener by our triage nursing staff. The result gets documented in our electronic health records, which is EPIC, and as requested, patient is connected to the resources. It was important for us to make sure that the screening flow is very tightly connected to EHR system. Currently, we are focusing on 5 different domains: housing, food, transportation, utility, unemployment. And for food, as you can see, we ask 3 questions, and the first 2 questions are actually the exact same questions that Liz has mentioned, the hunger vital sign. We do add 1 more question: is this an emergency? Do you need food emergency for tonight? It was also important for us to make sure that the screening result is well visualized to our provider. So we decided to place this result in the middle of the disposition tab. Sorry, I'm talking really fast because we don't have that much time. And for patients who indicate that they would like help with resources, and following alert pops up in the nursing context, we decided to use the best practice advisory BPA function of the EPIC. For patients who indicate that they need food for tonight, the next alert comes up, and as well as a automatic attachment of a food pantry prescription. So I'm going to talk about food pantry here. 1, 2, 3. Sorry, we're just like running out of time here. And then based on our pilot screening so far, we found out about 20% of our patients endorsed food needs, and about 4% of our patients endorsed food emergency, which is exactly why we need to continue to strive to improve this program.
So in summary, a food pharmacy is one of the many ways to begin addressing the challenge of food insecurity in our patient populations. Our general recipe for success is to first assess the needs in your community with a simple pre-existing questionnaire, involve your hospital administration early to ensure you can in fact distribute food, have liability coverage and adequate staffing to support, and then find existing partnerships in your community to access food and distribute and continue to evaluate the efficacy of your program for continued improvement. Thank you so much for listening. We'd like to now open up to questions. We have Dr. Baker from BMC and Dr. Shea from Harvard UCLA, who are the experts. Thank you for listening.
Yay. We did
Great, except you guys are the experts, and we're just facilitators. Henny's been working on this since she was a student, actually.
Oh, that's great. Cool.
Yeah, it feels like a million years ago, but it was
one thing to anticipate, or if nobody asks you, I would consider talking about the concept of charity versus equity in the current program, and how a goal state would be. I think this program is more in the category of charity, and with a little less with tools towards equity built in that we do have some activities that at BMC. I don't know, Henny, if you're versed in those, but things like the education on cooking and growing vegetables, and how people can better more efficiently use their money, their limited resources, and create healthier meals for themselves, rather than what often happens is buy fast food, which is cheaper or at least in the short term seems cheaper for people.
Sounds good. I was gonna, in terms of the food pantry, I was gonna talk about like the importance of the sort of the provision of fresh foods coming from the rooftop garden, and the volume that the food pantry serves, and how we could continue to sort of strengthen our partnership so that we can staff better, like in terms of, you know, people who are coming in during the weekends and overnights. Maybe we can have a little more strengthened program. So, hi Hannah.
Hello.
Are you in the middle of rounds?
Ajin was in the middle of rounds. I'm in the middle of like
Oh, I see. Okay, cool. Everyone's here. Do you want to practice your portion because we skipped it?
Sure. Yeah, we could go through the first couple slides, or my slides, I guess. That'd be great.
Starting from this one?
Staffing and streamlining. I actually can't see whatever you're looking at. Let's see. Oh yes, perfect. Okay, great. Hi, I'm Hannah. I'm a second-year resident in emergency medicine at Harbor UCLA, and I'd like to share with you some of the issues that we faced during our first year of actually running this food pharmacy. Certainly an interesting year to start anything new. So as we all know, residency schedules vary immensely and are pretty limited in their flexibility. And so what this led to was a wide variation in availability of volunteers and people who could actually attend the pharmacy to help distribute. Thankfully, it led us to streamlining our system and how we distribute our produce every week. And it's actually been a benefit that started out as an initial inconvenience. Another thing that we've learned through the hard way was to simplify the data that we were trying to collect. So we initially started out using a Likert scale to assess for our food insecurity of our participants, an initial visit, and then again at a repeat visit. This turned out to be a very complicated measurement tool for our participants to use and ended up providing a lot of data that wasn't very valuable in terms of its analytical value. We also had only Spanish and English surveys, and we found that a lot of our clients were speaking Farsi, Hindi, Cantonese, Korean, Russian, a wide variety of things that we didn't have surveys for or translation services available for. So from this, we learned that if you want to collect data, really think about what you're collecting and try to keep it as simple as possible. Also, doing things with COVID makes everything is changing all of the time. So we initially started with almost a food pantry, like a farmer's market setup where people would pick the vegetables that they wanted. This was ideal in our minds because it led theoretically to less food waste because people were only taking things that they wanted to eat. With COVID, we turned into prepackaged boxes, and then with a change in a grant, those boxes also went away because they didn't include meat and dairy that the USDA had required of the grant we were using. And so now we have just like bulk pallets of bulk pallets of produce that we distribute to people in a streamlined way. So just the lesson from this was to be very flexible in what you're doing from a week-to-week basis. And then finally, we would like to caution against trying to do too much. A lot of our food pharmacy was being done during a wild election season, and we thought that voter registration would be a valuable thing to add to our work. It wound up being a big privacy concern for a lot of the people coming to the food pharmacy. A lot of our clientele are not necessarily documented or here legally, and so it became a weird question answer, like, are you registered to vote? Well, no, and I don't want to talk about it anymore. And so we also realized that we didn't want to imply people needed to be registered, or even citizens for that matter, to obtain food at a food pharmacy. And so we quickly moved the registration away from the food pharmacy. So we'd like to advise against doing more as the enemy of doing well. So I'd now like to turn it over to our colleague at Boston Medical Center, Dr. Hong.
Great. Awesome.
Great.
That was quick.
Yeah.
I think that's right.
Yeah, only added like 4 minutes.
Okay, I'll keep it short.
Dr. Baker, would you like to introduce yourself in the beginning, or because I think all the residents are just sort of introducing as we start our own slides. I don't know how you would like to introduce yourself.
Is Dennis on yet, or is Dennis going to join us at the?
He is not on yet. I sent him the link.
I mean, I think it might be good if Dennis was, since he was the point person, just introduced everybody to the talk. I can introduce myself as well, and then each of you can introduce yourselves. I would suggest, I guess, in the order of your presentation, but I'll leave it up to you.
Okay. Well, we can see once.
So we're gonna have to be on here, right, for our screen.
Yeah.
So maybe you could use your laptop.
Oh, do I
to-
use my laptop?
To have it up
Oh.
to see the slides.
It's because I would need to get my keys in.
Oh, yeah,
Okay.
sure. Okay,
How's it going?
Dennis is here.
Yeah, you guys, I don't need to say anything. I'm just here for moral support. So your show.
You should introduce yourself.
Oh, sure. I'll introduce myself.
I guess so. In the beginning, it might be more time efficient to just say after Elizabeth gives the intro, like you'll say, "Hi, I'm Elizabeth." Blah 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 blah. Hi, I'm Eugene. Blah blah blah. Because I'm going second, and then Hannah does her intro, and then
Yeah,
Or-
I don't know, because whatever we want to do. I think it might take more time to introduce everybody at the first slide because
Then
there's those
just-
pauses in between
Okay.
everybody.
yeah, then I guess just introduce yourself with name and year and location before
What do you want
your
me to
slide.
pull
The PowerPoint slides.
Okay.
Google
up? You guys
Okay.
send that's it too.
Last minute.
Okay, sounds good. You send them my DHS email?
Is everyone okay with
No,
that?
actually, you're CC'd.
Oh,
And then
okay.
we can introduce like Dennis and Dr. Baker at the Q&A session part.
Yeah.
Yeah, that works.
Yeah, that's fine. We're not. You guys are doing all the work, so.
Liz, do you want to, in your conclusion at the end, then just say like, we'd like to introduce our like faculty support, basically, Dr. Baker and Dr. Shea, and they'll be joining us to answer your questions.
Yep.
Who's moderating this session?
I guess like Elizabeth. in the
Yeah, Liz
beginning.
is in charge here.
Yeah.
And I'll be your medical student ambassador. So if there's any sort of issues, I can go ahead and try to fix that. And I can also help moderate the chat and whatnot.
Oh, wonderful. Thank you.
Okay, so we don't have an assigned moderator, correct?
I will double check that right now.
We're all family anyway, right? Same household.
That's fine if we don't. It's actually better because it'll slow us down if we have a moderator.
Okay, then I won't check.
Well, I mean, it'd be nice to know because sometimes they show up right at the start and I don't want them to muddy things up.
Sure.
Okay, so when you open it, you should see this most active version, but let's try to get into the room. So we join.
Oh,
Willie,
yes, I know who the moderator is, and she is right here.
Oh,
Okay.
Dr. Price.
oh, so she is Dr. Price is the moderator.
Exactly.
Lily, I cannot see the chat because I'm the one who's sharing.
Might have to-
Dr. Price?
Yeah, sorry, you guys. I got locked out for the 10 minutes I've been waiting there. Is there something I can do to help?
They were just wondering who the moderator was.
Yeah,
and
it's,
looked and we found you,
it's
so
so irritating. to
You're
not have,
fine.
like, oh. But who's got that feedback? Is it because there's a phone and a screen open at the same time?
it might have been, but I think the feedback is gone now, I think.
Okay,
Oh,
excellent.
but I think we lost Eugene and Hannah.
So it might be because that's why the feedback is gone.
Yeah.
I'm letting them in the waiting room right now.
They're on Juno right now. We're trying to get them back to Zoom.
Oh.
Oh, they're here. Welcome.
Can you make Hannah a co-host, please? Thank
Hey,
you.
Dr. Baker.
Hey, Dennis.
No, I'm good. Just hang off to the side. How's it going?
Great.
Okay. Great. Okay.
It's a fun fact.
Yeah, so if you guys are all ready, you guys feel free to start whenever you guys want. But yeah, go for it. Everything's being recorded.
you guys want to start with the number?
Yeah, I guess Liz will start. So maybe we should be on mute until we're talking.
Yeah.
Great. So hello, and thank you all for joining us for our discussion on this important yet often overlooked topic of screening and addressing food insecurity in the ED. My name is Elizabeth Scott, and I'm a first year EM resident at Harbor UCLA. Our presentation, next slide. Our presentation today includes representatives from LA County, Harbor UCLA, and Boston Medical Center. We have no financial disclosures.
Hi everyone, my name is Aijane. I'm an intern at Harbor UCLA in EM. So I wanted to start off by introducing what food insecurity is. The data defines food insecurity as the limited or uncertain availability of nutritionally adequate and safe foods, or uncertain ability to acquire such foods. There are 4 gradations of food security seen here. Recent estimates during COVID find food insecurity to more than double from 2019, affecting as much as 23% of households, hitting households with children the hardest. Per the Brookings Institute, 13.9 million children in the US lived in a household characterized by food security. So our social histories in the ED often ask about smoking use and medical problems as hypertension and diabetes, but this data from the CDC suggests we should really be asking about food insecurity. More deaths are associated with food insecurity than tobacco use. Furthermore, a 2020 paper in the Western Journal of Emergency Medicine reports patients screening positive for food insecurity in the ED were more likely to be admitted to the hospital and have significantly higher HbA1c levels. Eating better not only saves lives, it saves money. This chart from the Sodexo Foundation back in 2007, we anticipate that these costs have only risen as healthcare continues to increase in price. Food is a billion-dollar industry. Millions of dollars annually are poured into advertising alone, primarily for highly processed food. Problematically, these advertisements are largely targeting our youth and economically disadvantaged populations. The 2012 Federal Trade Commission reports food companies spent over $149 million in schools in 2019. 93% of which was marketing for sugar-sweetened beverages to kids that contained an average of 19 grams of added sugar.
So looking at the importance of food insecurity to health, we asked ourselves, how does this apply to our patient population? At Harbor UCLA, we serve a lower income population in South LA. We use the hunger vital sign, which is a simple 2-question model that can be used by busy ED physicians or staff members to identify those at risk for food insecurity. The hunger vital sign was originally validated in the pediatric literature by Hager et al. In 2010, and then subsequently applied to adults. We also designed a food prescription for our EMR system that can be printed with discharge papers to refer patients to the food pharmacy. We've learned a lot through the process of creating, maintaining, and beginning to study the efficacy of the food pharmacy. From the beginning, Dr. Shea was able to utilize existing organizations in line with our mission to form vital partnerships instead of starting from scratch. For example, the American Heart Association was already actively working to distribute produce in other LA communities, and we at Harbor were able to partner with them for ongoing support of the major of bringing food to our pharmacy every week. Additionally, we partnered with Food Forward, a local organization that reduces food waste through collecting excess produce from farmers, grocers, and local harvesting for redistribution. This process creates a win-win situation of reducing food waste in addition to providing better food security for the community. In addition to those valuable pearls in creating partnerships, we've definitely experienced our fair share of pitfalls in this process. Maintaining our original prescription model, as seen on the previous slide, where a patient was directly referred from the ED with a paper prescription, became increasingly difficult to maintain, especially during COVID. And we now operate on more of a word of mouth model. This makes our current setup more of a food distribution center as opposed to a strict food pharmacy, but allows us to also serve a wider population of the surrounding hospital instead of just limiting us to those who present to the ED.
Hi, my name is Hannah. I'm a second-year emergency medicine resident, also at Harbor UCLA, and I'd like to talk to you about more of the day-to-day or week-to-week process of the food pharmacy.
So as we know, residency schedules vary immensely and our availability is really limited in terms of how consistent we were able to be in terms of weekly responsibilities. So because of COVID also, we had a extreme shortage of volunteer availability, and we ended up creating a very streamlined food distribution system that was sort of a benefit from the otherwise difficult situation of having consistent volunteers. Another thing that we've learned along the day-to-day process is to simplify what we're trying to collect. So we initially started with a survey that included a Likert scale to measure our clients' food insecurity. This turned out to be far more complicated in terms of collecting data that actually had any value analytically from our clients. We also realized that only having Spanish and English surveys was not sufficient to satisfy the needs of our clientele, who also speak Farsi, Hindi, Korean. There's just a lot more languages than we realized in our community that we weren't able to collect data from. So we would recommend keeping things as simple as possible. Similarly, starting anything during COVID is always an exercise in flexibility. So we had a wide variety of ability to distribute food. We initially started with a farmer's market setup where people chose the food they wanted. This was ideal in our minds because it allowed them to take what they actually wanted. And we thought that we'd be minimizing food waste in that setting. However, with COVID restrictions, we then turned to a boxed distribution center where everyone had the same amount of produce in each box and people just walked up and took a box and left. That was good. We also didn't know how much was actually getting used because people had no choice. And now we have a streamlined system where people point to what they want and we put it in their bags for them. And then they walk away with exactly what they've requested from what we have that week. So stay flexible. And then finally, we thought that adding in extra things to the people in line would be an efficient use of our time. And in fact, it was actually not a very successful endeavor. We tried to add voter registration for our clients waiting in line for food. It turned into a privacy concern, as many of our clients were not necessarily citizens or even necessarily here with papers or legally. And it turned into a situation where maybe our clients felt that they needed to be citizens or have an ID card to get food. And that was exactly the opposite message we wanted to send. So we quickly turned away from trying to do voter registration at the food pharmacy. So we would advise, again, if you're interested in starting something like this, just keep it very simple, stick to the mission. I'd like to now turn it over to Dr. Hong from Boston Medical Center.
Hi, everyone. Thanks, Hannah. Hi, everyone. My name is Henny Hong. I'm a second-year EM resident at Boston Medical Center, all the way at the opposite coast from the UCLA Harbor colleagues. Honored to be here today. I wanted to briefly talk about what Boston Medical Center is doing to address our patients' food insecurity. So since 2017, BMC has implemented a program called Thrive that focuses on screening and addressing our patients' social determinants of health. Since September of 2020, we have begun to implement a partial screening in our very own adult ED, focusing on patients who meet the ACO criteria, so Medicaid and no insurance. So current flow includes any eligible patients who is registered gets screened by our triage nursing staff using a validated screener. And the result gets documented in our EHR, which is Epic in our case. And as requested, patient is connected to resources. It was important for us as we were building this program to make sure that the screening flow is tightly connected to our electronic health records. So I wanted to share with you what it looks like in the context of the nursing staff as they are screening the patients. We are focusing on 5 different domains, so housing, food, transportation, utility, unemployment. For food, we are asking 3 different questions, as you can see. And the first 2 questions are actually exactly the same question that the Harbor colleagues are using. It's actually the hunger vital signs. And the last question, we do add one additional, which is this an emergency? Do you need food for tonight? So asking for the food emergency. We also wanted to make sure that the screening result is easily visualized by our providers. So we decided to place the screening result right in the middle of the disposition tab, as you can see. For patients who indicate that they would like help with resources, We created a alerting system, so our providers are made aware of the screening results. And the current, as you can see, the best practice advisory, the BPA alert, will pop up for the nursing staff, letting them know that social needs related resource guide will be attached to make sure they have a conversation with the patients regarding the resource. For patients who indicate that they need food for tonight, the similar alert pops up in addition to an automatic prescription to the food bank, the food pantry that we have at BMC. So this food pantry prescription program is quite new, low touch intervention that we implemented pretty recently, January of 2021. And we're just beginning to measure the referral connections to the pantry. It's actually pretty amazing. So through this pantry, our patients can visit the pantry a maximum of twice per month, and they can receive 3 to 4 days worth of food for their household each time. And the key feature is provision of perishable goods, including fresh fruits, fresh vegetables, and meats, items that are often costly and therefore lacking in a low-income family diet. What is most impressive to me is that a lot of majority of this fresh vegetable and fruit gets supplied by our very own rooftop farm. Despite the harsh weather Boston is known for, our team somehow figured out to way to grow enough vegetable and fruit to supply for this food pantry. In 2018, the food pantry has supplied about 83,000 patients or their family members, and an average of 6,900 patients per month have benefited from this program. This program is a separate program from our ED, and this recent collaboration is very exciting, but it's certainly not perfect. Food pantry is only open between 10 a.m. and 4 p.m. Monday through Friday only. And so ED patients who are in the ED outside of those time windows cannot benefit from this resource. So we're hoping for more direct collaboration in the future with food pantry team to maybe implement programs like emergency food box that's available for overnights and weekends. And maybe one day we'll be able to bring a food box to the bedside, sort of similar to the Meds to Beds program that we have at BMC. From the pilot screening so far, we have found out that approximately 20% of our ED patients endorsed food insecurity, and about 4% of the patients endorsed food emergency, which is exactly why we need to continue to strive to improve our program.
So in summary, a food pharmacy is one of the many ways to begin addressing the challenge of food insecurity in our patient populations. Our general recipe between the Harbor strategy and BMC is to first assess the needs in your community with a simple and likely pre-existing questionnaire. Then involve your hospital administration early to ensure you can actually distribute food at your hospital, have appropriate liability coverage and adequate staffing to support a weekly or however often you plan to distribute food. And then find organizations who are already in line with the mission to partner with in your community to access food and distribute, and then continue to evaluate and evolve and see how effective your program is. So thank you so much for your attention. We would now like to open it up to questions and also introduce you to our faculty support, Dr. Willie Baker at BMC and Dr. Dennis Shea at Harbor. So it looks like we already have one question in the chat, and I think this is for our BMC friends. Cynthia Price asked, who keeps track of the no more than twice a month? I think this is referring to your food pantry.
Oh, so at this point, the ED side does not do much tracking at all. This collaboration is pretty recent. We're still in the middle of assessing how active, how many patients are actually walking over to the food pantry. So we don't have the data of, how many of our patients are actually showing up twice per month to utilize the maximum number of times they can use the pantry. So right now that tracking is done by the food pantry team.
Yeah, I was more concerned, like, how do you make this not the neighborhood grocery store for everybody to come in and do an ED visit and then get food for the day or 3 or 4 days every day, every week?
It's certainly one of the barriers that we are expecting. Because we are currently only doing a partial screening. So right now we're, as I mentioned, only screening ACO patients who are Medicaid and no insurance only. That actually cuts down to less than 10% of our patient volume. So at this point with our flow, this food emergency related pantry prescription has not elevated to the point where patients are sort of quote unquote like abusing the system to look for what they need. But before we sort of expand the system, the screening and the referral system further, I think that's something that we definitely will need to work closely with the pantry team. I don't know, Dr. Baker, if there's anything else. Yeah.
Yeah, this is Willie Baker. Thank you very much, everybody. This was a spectacular presentation. I know you guys collaborated quite a bit on this and practiced this and put it together. I'm Willie Baker. I'm one of the faculty, obviously, at Boston Medical Center. And to sort of elucidate on a couple of other points. So it's not all Medicaid or no pay patients. It's those that are part of our accountable care organization, which is a smaller portion of that payer mix. And we have as an institution, although we're not technically a public hospital since 1996, we are a safety net hospital, and 80% of our visits are paid for by some form of government insurance. So we have very little in the way of commercial payers. And this program, as it stands now, is not yet overwhelming the food pantry, although there is certainly a danger of that. I don't know if it becomes more, let's say, popular. It's not our only goal with respect to addressing food insecurity, though. We have other aspirations beyond the prescription and a box of food.
Yeah, and I think from the perspective, right, it's all about how do you draw the balance, right? Like if someone's really willing to go through the effort to show up for us Wednesday mornings to pick up the food, I think they're probably, from a cost benefit perspective, they're showing that they have a need. So I think, for us, yes, at some point, maybe there's going to be one or two people who don't need it, who take advantage of the system. But I think from our perspective, it's really, how do we do the best good for most people without becoming overly regulated? Especially sort of if you look at, on the flip side, our public benefit system, where there's so much focus on fraud prevention. And if you actually look at the data, there's very little, if any, fraud in many of these cases. And there's all these hoops, which results in a lot of harm. So I think your point, Dr. Price, is very well taken. But I think you sort of have to do a balance and sort of draw a line where you and your team feel comfortable as to where you feel like you're helping the most people without creating additional barriers for vulnerable populations.
Thank you, Dr. Shea.
Feel free to add any other questions to the chat or just unmute yourself. I think we have like a minute or two.
You do have just a little bit of a minute. I know there's some differences between the market style and then those that actually be tied to an ED or a clinical visit. Any thought to look comparatively to see which one of those is more effective for your last minute?
I think the literature looks mostly not so much on location or style based. It's a good question. So it might be a good place for research for those of you interested. I think most of the literature focuses on certain conditions that one would expect to be food sensitive, such as diabetes or heart failure or things along those lines. So it's I think a great direction for future research, but this team has much more knowledge, so they might have some thoughts.
I mean, I think eventually it would be nice to have multiple streams that bring people to the food pharmacy, and it would take coordination amongst different departments to make it a consolidated hospital effort.
Right now, we partner mostly with the family medicine department.
Certainly from your, Judy, did you have your hand up? No, just making a scratch. From your moderator, looking at social determinants of health, these are our patients and we have to cultivate care. So I appreciate that you guys are working on both coasts from two different directions to try to help close the gap. So thank you everybody for joining us today. Have a lovely afternoon. So a few more sessions on board. So click and get to your next one. Thanks.
Thank
you,
everyone. Thank you.